dark night. She reached up to the sky of stars and caught the red-hot light of the North Star. The earth, walking with blood-soaked feet. She challenged the whip, the gun, the knife. She challenged the fire, pulled from the bodies of slaves, made into laws, prisons, and courts. Screaming white-hot flames and agony, she challenged millions of headhunters, dragging and ripping apart impossible tender moments of time, shipping vessels of history, ancient history, destroying the fabric, the godlike claw of destiny of a people with a gun, a knife, a cannon, building the hideous wall of blood called slavery. She challenged it with burning eyes and black skin, torn skin, whipped skin, degraded skin, smashed skin, dehumanized skin, dehumanized skin. Strong enough to bring a fee, strong enough to be free, to be free. To be free, strong enough to bring a fee, strong enough to be free.
Greetings, and I hope all of you watching and listening had a wonderful, wonderful weekend. If you look at the narrative that has been out about Trump's so-called big, beautiful bill, or what we really know as the transference of wealth from the working class and the poor to the wealthy, is that the resulting cuts in federal health spending of about $1 trillion over a decade will be in ways that will jeopardize the physical and financial health of tens of millions of Americans. But if you just focus on that narrative, you might be inclined to overlook the cuts that hospitals are making and have been making prior to the passage of this huge, ugly mistake. What's going on and why? Let's connect some dots and find out.
Connecting the Dots with Dr. Wilmer Leon, where the analysis of politics, culture, and history converge.
Welcome to the Connecting the Dots podcast with Dr. Wilmer Leon, and I am Wilmer Leon. With each show, my guests and I provide insight and analysis into current events and the broader historical context in which these events take place. Before we get to my guests, let's take a quick look at some of today's headlines. According to antiwar.com, Gaza's health ministry reports spike in starvation deaths due to Israeli blockade. The ministry said 18 people died of malnutrition in just 24 hours. The health ministry said in another post on Telegram that it has recorded a total of 86 deaths due to hunger and malnutrition, including 10 adults and 70 children. Quote, "This is a silent massacre, and the Ministry of Health holds the occupation and the international community responsible. They demand the immediate opening of the crossings to allow the entry of food and medicine into the region." Next story is that President Putin and President Trump could meet, and I underscore could meet, in China if Trump agrees to go. According to the Kremlin, Russian President Putin is going to Beijing in September for the celebration of the 80th anniversary of China's victory over Japan in World War II. And Putin could meet with Trump if Trump decides to go to China. This is according to Kremlin spokesperson Dmitry Peskov. Talk about flipping the script. Let's see if Donald goes to China. Harvard slams the Trump administration for funding cuts in pivotal court hearing. Harvard called the government's rationale for cutting billions of dollars in federal funding illegal and cooked up, if not contrived. Attorneys for the nation's oldest university sparred with a government lawyer earlier today in a legal showdown that could determine whether the Trump administration's attempts to cut billions of dollars in university funding is legal. On today's episode, the issue before us is the status of and projection for access to quality health care for the average American. My guest is a board-certified anesthesiologist and public health activist. She's a distinguished medical expert and thought leader in the field of race and medicine, Dr. Kendra Outler. Dr. Outler, welcome to the show.
Thank you so much for inviting me to have this very... Hold on, am I unmuted?
No, we hear you.
Okay, thank you so much for having me, giving me the opportunity to have this critical discussion with you at such a critical time. It is probably overdue.
Well, it may be overdue, but it won't be the last time we do it. So let's start there. So the Center for American Progress reports those who need Medicaid most, including people with disabilities and the elderly, will be affected by the bill's cuts. The nonpartisan CBO, the Congressional Budget Office, estimates that this bill will cut federal spending on Medicaid and children's health, the CHIP program, by $1 trillion, due in part to eliminating at least 10.5 million people from the programs by 2034. I said in the open that if you just focus on that logic, you might be inclined to overlook the cuts that hospitals are making right now and have been making prior to the passage of this huge, ugly mistake. Your thoughts?
One big area that, in terms of the statistics that you need to put forth, Dr. Leon, is that about 1 in 3 births, meaning women who are getting ready to deliver, receive Medicaid to help them through that delivery process. Okay. That means that we have the children, we have the elderly, we also have women who are pregnant and expected to deliver that the Medicaid cuts threaten to pull off. And we've done a lot of Medicaid expansion to help women not only deliver safely over 9 months, but then particularly here in Illinois and other states, we fought long and hard to have women continue to be on Medicaid for up to a year after delivery so that they can get access to medications, they can be screened for hypertensive disease, preeclampsia, and this was in an effort to, with the White House initiative on the Black maternal health crisis. So my thoughts are that all populations are going to be affected. When it comes to men's health, the Medicaid services have directly helped them access mental health needs. One of the things that is being touted is that able-bodied people need to get off. Well, there are people with mental illnesses that we physically cannot see, but there are reasons that they need Medicaid assistance. So it is a big, large group of people, cross-section of people. It's not just the poor. And this is going to steamroll into the working people who have to need access as well. So we're all in jeopardy of limiting our ability to get critical health care needs when we need them. We're all at risk. So this becomes a bigger conversation for everybody.
When you talk about 1 in 3, so you're talking around 33%. A lot of people, let me put it this way. Explain a little more about the type of coverages you're talking about and how that money gets paid or disseminated. Because when people hear Medicaid, people think poverty. So if you could expand on that a little bit, please.
And that's not how the money gets allocated. I will say that every state has a Medicaid budget, a budget that assists patients, particularly when it says Medicaid. It is aid to dependent women and children, and also for persons with disabilities. That's where you get the mental health and maybe find men that are on disability, okay, or need Medicaid. So how that money flows, it depends on the state. Maryland has different allotments for their Medicaid and assistance to an individual, to a family, to a woman in particular, or for a child with cerebral palsy, with Down syndrome, that is deemed appropriate after a review. When a woman becomes pregnant, they can apply for assistance so that they are not without health care, so that we can care for her and her unborn child. And if she then returns to work, or her case is reevaluated, then she can come off Medicaid. So how states do that in terms of how the money flows, that is a per state. This is when we get into the conversation of the Affordable Health Care Act, where certain states, particularly your southeastern states, your red states, did not expand Medicaid, expand the option so that people can purchase into the Affordable Health Care Act. So there are a lot of policies around that. I'm not a health policy expert, I will admit. And also, I'm a full-time clinical physician. So, some things I don't look at. I don't look at hospital bills. What I do look at is patients who come to the hospital in critical needs, particularly in anesthesia, or need access to surgical services. And you can see delays. You can see the need from the emergency room up to the operating room suite. And it's very apparent that this crisis is going to affect everyone.
Talk about, as I mentioned in the open, that a lot of people, and rightfully so, are focused on the bill that was just passed. But you and I were talking earlier about the fact that there are cuts that are being made right now that aren't being focused on. How significant are these? What kind of cuts are we talking about, and how significant are they?
So we've had a transformation of the hospital care system from these big hospitals. Most people can remember big hospitals like Charity Hospital. Prior to COVID, if you were in the Philadelphia area, you had Hahnemann. Hahnemann closed in the middle of a pandemic because it was bought, it was sold almost as real estate, not as a place for healthcare. So what we have is that our hospital, the realization that our hospital is a business, and the business has to think about projections and projections over time. So therefore, if you are at a hospital right now in what we call on the business side, the C-suite or the executive suite, you're having to make projections like any other business. The tariffs are hitting businesses hard. They have to think about, am I going to be able to run this facility with products? What are the products of hospitals? The products of hospitals are gauzes that you use, bandages that you use, your personnel, your nursing staff. We have paraprofessionals, respiratory therapists. We have equipment. We have to buy large equipment like MRI machines. And hospital systems not only cover, they're not just one place now, but you could take a facility like Emory in Atlanta that has a lot of community hospital access points. So they'll tell you, okay, well, you don't have to come to the big hospital. You can go to the hospital in your community. So we've transformed medicine so that people can have, quote unquote, access to their hospital in their community. So you are the CEO of a large facility or hospital system, right? Northwestern, here in Chicago, Rush, University of Illinois, Maryland, Johns Hopkins. And so, we have hospitals in our areas. Well, they feed into one major system, and that system has to start to make projections on expenditures. So when you see that over 10 trillion is going to be cut over years, you start to say, well, how much do we need to conserve over the next 3 years in order to provide this, to keep our doors open? And so that's what hospitals now have to prepare for, even though the bill hasn't been signed, even though the final strokes of ink have not been put in place. As a business projection model, the hospital systems now have to act in that mode. So what does that mean? That means starting to look at volumes in clinics and which ones get referred up for critical access, expedited care. We've worked really hard to get people colonoscopies because we've become aware that younger and younger people have colon cancer disease. And so now you have to start to say, well, which ones can we screen? Which ones can we wait on? And what you'll see is a different type of messaging going out to communities that say, well, maybe we can wait for this group of people. Maybe we can move people from this clinic to this clinic, and we can close this clinic early. And all of this is in a balance to keep the dollars conserved when the federal government stops reimbursing for certain costs that hospitals oftentimes have to absorb.
You spend a lot of time focusing on the disparities of health care delivery and race. If we also factor in economics here, because we're hearing a lot of rural hospitals are in jeopardy. And when you start talking about rural hospitals, depending on where you are in the country, but to a great degree, you're talking about folks that actually voted for this, and now they're finding their hospital, their access to that local clinic may be in jeopardy. And so I think we can see things happening on two extremes, one on the rural side and one on the urban side.
We do have critical access hospitals, critical access hospitals. Those are your rural access. You also have your safety net hospitals, like your rural hospitals, and you have your critical access hospitals, like your urban hospitals. So the idea that both of them will be very, very much affected is true. I think we still have to focus on both of these hospitals. I think your rural hospitals are more in jeopardy to be closed Again, the option for rural patients would be to go to their safety net hospitals, your critical access hospitals in the larger cities. So my family's from rural Georgia. We have to go, for instance, my father, if something happened to him, he has to go 28 miles to the nearest town. And then he would have to travel almost an hour and 15 minutes to his VA hospital to get care. This is a very real scenario that families in communities will have to face in places from Georgia to Iowa to across over to California, New York. But we also have urban centers. If you think about the dense population of people in South Philadelphia, we have to think about their transport time into the Pennsylvania area to get care.
So they're talking about cutting off over 11 million people off of Medicaid. And as this was being presented to the public, a lot of Republicans were saying, oh, no, we're not removing people from Medicaid. What we're doing is we're changing the requirements. So so as though changing the requirements was not going to have an impact on people who actually qualify for the service. How concerned should people be?
I'm going to say the call to action is that our community needs to read the fine print. We got to read the fine print. We have to start to realize that they're talking to us, and what is going to be affected is going to happen in our community. So we can dance around what they're doing all day long, but the fact of the matter is the bill has passed. There is a target threat and the undoing of Medicaid, Medicare, and the health coverage as we know it, that everything from work requirement proposals, when you have people right now, particularly like last week, we saw people losing their jobs with the State Department, potential close, letting teachers have to go home, due to budget shortfalls like we have here in Chicago. So people are losing their jobs, and then you have a work requirement, and then they're saying that they're not getting rid of something, but they're changing the structure of it. You're in effect getting rid of it. There's no way around that conversation.
You are and the examples that you just used. You're talking about people when you talk about State Department and educators. So you're talking about people that had, I'll say this just to make the point, 40-hour work weeks and healthcare. But what we've also noticed over the development of this economy are gig employees, people that are driving for Uber, people that are delivering food.
That's a good point.
And so those types of jobs don't necessarily have the same type of reporting processes that a State Department worker had, an educator had. And so now they're putting additional requirements onto a system that was never really designed to provide the kind of data that they're now requiring.
I think definitely, and that's an excellent point. I think that as we have evolved, people have, we forgot about the Uber and people who have unique forms of entrepreneurial jobs. And so where do they do their reporting? One of the problems with the work requirement is how is that going to be reported, validated? What they've seen in states that have done the work requirement before is that it didn't work. It didn't work because there were glitches in the system. You actually had to create a system with people and computer links and a phone system that people had to be responsive to. And what they found is that people have busy lives. If you have a child that needs care, or you are providing care for an elderly parent, a lot of my generation, we have to take care of children at home. You also have to take care of parents, and then you're supposed to either get on the phone or find a link and then contact someone and let them know how many hours you're working or trying to do work and training or what have you, so you can keep your insurance. Well, life gets busy for some people. So, there was, the movie Sully was said, we'll make it human. So I don't know how they're going to make the process human. That begins to be seen. But it does threaten people's ability to not have a lapse in coverage. And let's say the lapse in coverage happens when you end up with a stomach ache and you end up in the emergency room, and next, lo and behold, you don't have coverage. So that's the danger in the conversation. We're not only forcing people out of the workforce, and you actually, some of these people may say, okay, well, I can Uber to sustain my family because the bills keep coming, right? And so now, how do I report that I actually have an income? This is going to be a big conversation. And this is why we have, as communities, to stand up, get involved in some of the meetings that are happening in your state, in your city, give some feedback on how it's working, not working, or what the potential concerns are, so that there could be some grassroots actions potentially to get some reasonable ears to the needs of the people.
In fact, you just mentioned the bills keep coming, but you take 11 million people off of healthcare. That doesn't mean that those 11 million people aren't going to still get sick. So as an emergency room physician, you're going to, if you aren't already seeing more people come into the emergency room as their initial point of care because they have no place else to go. And so I'd ask the audience, vote those of you that are writing in, how many of you either are finding the emergency room is your, and I'm using, I don't know you can tell me what the proper medical term would be, principal or initial point of care. I don't know any other way to put it. How many of you listening and watching this have to go to the emergency room because you don't have a primary care physician, Dr. Outler?
So I used to do emergency medicine. Now I'm in anesthesia. But what I can tell, and the benefit of that is that I know the struggles that people have on the primary side and the emergency side, and then finally need to have surgery. But I tell, even in the best of circumstances, somebody's healthy could end up sick. Okay, you didn't plan on your gallbladder your pain. You didn't plan on your appendix rupture. You didn't plan on falling and breaking your leg.
I didn't plan on slicing my finger to the bone, cutting a tomato to make a salad.
That's right, exactly. And so these are things that happen. So you didn't plan on the car accident. So some young people in college or what have you, 20 to 30, you typically are not really worried, ideally, about certain things. You may not have hypertension, diabetes, so you don't have a primary care physician established, but you could end up finding yourself in the thralls of a medical emergency. So you're still going to have those patients in the emergency room in need of surgical care or some type of intervention. I mean, something very common that young people can get is an abscess, and then next thing you know, they're in the emergency room because they're like, well, I don't have a dermatologist, I don't have a family doctor. That's understandable. So we have these type of patient visits all the time. What people tend to focus on are the burden of people with chronic disease. But there's no but. These are in addition to the person that was driving, that's young, 25, and all of a sudden find himself in a major car accident, maybe with 2 or 3 other friends. We also have to talk about gun violence. It affects a lot of our young Black youth. Okay, they may not have established care because they're healthy. And then maybe they only need to see a doctor for a sports physical or what have you. And now all of a sudden the families having to deal with multiple hospital visits, critical need, surgical interventions. So we have to think about those emergency visits plus those with chronic disease that end up in the emergency room at the same time. In the 80s, and even now, you could go to the emergency room and say, okay, well, I think that I just need to go in here and I'll be out soon. And the next thing you know, they're like, I'm sorry, but we won't see you for 6 hours because we're backed up with a major injuries to patients. The emergency room is a triage system, so they decide which ones need to be seen first and which ones can wait. The threat right now is patients that are going to delay being seen, that have chronic illness, that are out of their medications. They become critical, and those patients could come in at the same time that we have life-saving injury, life-saving issues like gunshots and traumas and stabbings and things like that. These things are still going to happen.
And we're seeing mentioning gunshots. Aren't we seeing a rise in gunshot victims?
We are. And this is the issue that we're in now, which is a whole nother show, is the restructuring of the CDC, restructuring of the Health and Human Services in terms of data collection. The data will tell the story. You can make the data say it's not happening, but in real time, we've had major what we call mass shootings across many cities, and that is real. That's not make pretend. So we really have to think about. We report on Chicago a lot. I was talking to a doctor last night from Memphis, Tennessee. We have mass shootings that happen across this nation. So, right now, unfortunately, the data is not really being highlighted and collected as rigorously as it was. If you go to the CDC website and pull up some of these things, they're not there. So we do have, you were able to start of the show, your headlines. One of the headlines that hasn't been as big as some of the other issues in politics is the dismantling of some of these reporting agencies like the CDC, the NIH, and the Health and Human Services.
In fact, one of the things I was just going to get to was that there's a rise in syphilis in this country, and HHS and CDC, the data on that isn't there.
Well, it's become, for instance, the maternal health data team. I think that was disbanded about April. So any reporting on anything, particularly like the measles crisis,
in April,
is not there. You have to rely on AI generated information. You can try to go to your state public health website. University of Texas, if you're in Harris County, look there. But, where are the numbers? That is the question. Where are the numbers for measles? Where are the numbers for sexually transmittable diseases like syphilis, which can have harmful effects in pregnancy, gonorrhea even, because we think of things existing. But what does this lead to? Why is this even, is this some type of, you want buzzwords for measles and syphilis? No, we have to think about communicable diseases. We have to think about the fact that we had an ability to control these diseases. And we also have to think about, are we going to see an increase in HIV and HIV cases? And this is a big deal, particularly for minority or Black and Hispanic communities across this nation, which already look at higher rates of disease and the burden of HIV and AIDS in our communities. And so, the question is, how do we safeguard ourselves if we don't know what's going on? How do we use protection, whether that's hand washing, masks, whether it is, other protection measures? So grassroots organizations are being handicapped with their ability to do community interventions, which we know work.
2 points. One, Peggy Parks Miller, who is a member of the Connecting the Dots team or club, asks, will the people who show up at the emergency room with no insurance be treated?
Absolutely, they're going to be treated. We even when we had the 70s and the 80s, they were treated. You're in a triage mode. There is no not treating patients. That doesn't exist.
And Kevin Baptiste, thank you, Kevin, greatly for that $20 super sticker. Kevin is a nurse. Our EDs are already seriously impacted. Before these cuts, we have had recruitment issues because less and less folks want to get into nursing, and our patient census is off the chain. Your thoughts, Dr. Outler?
Well, we're having recruitment issues in healthcare across all specialties. You know, nursing is definitely impacted. We have to think about, we have to get creative. This will impact retention bonuses. This will impact recruitment out of colleges. My thoughts are that you need to be very engaged with your legislature, with your, for instance, the Black Nurses Association. See what uh, messaging that they're doing, what type of grassroots actions that they're doing. This is truly a time when social media with our grassroots opportunities need to kind of marry. I think that why I thank you, Dr. Leon, is that we as Black community leaders that work and to get messages out to our communities, we got to work harder and we've got to be engaged. We've got to continue to spread the word across all platforms and all of our shows to start to having meaningful conversations with not just myself, but with other Black physician leaders that say, this is what's going on in my area. So I think that my thoughts are just that this is going to, things are harder now, but I don't think they're impossible. We've just got to leverage the resources that we have as communities. We've got to leverage our ability to communicate what is going on social media, across YouTube programming, across the radio. I mean, opportunities on the Breakfast Club to start to say, hey, we got to really rap about this. What is going on?
Besides the obvious, are there hidden consequences to the funding changes that this so-called, the bill is set to do? And one of the areas that many might not think about this is the HBCU landscape.
Yeah, that is one of the hidden costs right now. We have to really think about what this bill is saying to a young person who's anticipating going into the health space that have been identified themselves. I went to the High School for Health Professions in Houston, Texas, so I knew very early that I wanted to go into the health career space, but limitations on how much you can take out for student loans. As your caller mentioned, my thoughts are how are we going to finance education? That is a real process here. In other countries, you may have a service requirement that covers your educational costs. Well, that's not how that works here in the U.S. You can get a scholarship. Are those going to be limited? But for medical school, only so many get a full scholarship. So what are our options for young people to finance an 8-year educational process? How are our HBCUs being asked to realign some of their messaging and focus areas so that they can continue to get federal dollars? What those cuts look like for the HBCU medical schools like Meharry, Howard, Morehouse, King Drew. I think that their leadership needs an opportunity to come to the table and discuss that either with the administration or on platforms to say, these are the physical cuts that we've had to make. If grants from the NIH, I had a friend lose hundreds of thousands of dollars in grant dollars. That was painful. And I just, tried to tell them to stay encouraged. But that takes a lot to write what we call an R1 grant to get funding from the NIH. It's a 6-figure number, and then being told, sorry, your grant addresses health disparity. It's our health equity. Therefore, it won't move forward, and we're taking that money back. You don't get those grants overnight. Those grants don't come easily. So, and it also stops all of the work being done. A clear case right now, people, and I'd like for you to follow the conversation on this, is what happens to the sickle cell funding. It's a big conversation, and we're going to have to, let's say it is a Black specific conversation, whether you're from the diaspora or from, South America, South Philadelphia. The point of the matter is that there are communities that have sickle cell. Other nations address sickle cell as a public health disease. We do not. So people require Medicaid and insurance to help them. So this is how this can affect us, and this is kind of like the behind the scenes conversation that we're not seeing in the mainstream media, that we might not really be appreciating, as everything from data collection, hospital reorganization is happening.
In fact, you mentioned sickle cell, and I have a very dear friend who I think it's every 6 weeks has to get a complete blood transfusion, and he's on disability. Who's going to pay for that? Are we just supposed to kick him to the curb and say, well, hey, buddy, sorry. Every life.
But what about his work requirement?
And he can't work. So there you go. And okay, we've made that point. Robert Brown. Go ahead. No, go ahead.
No, I think that this is what I'm saying. When we say make it human, these are the things. Whether you have sickle cell, or whether you're a young woman with breast cancer or Crohn's disease, they're small. They don't, what have you. What they define as able-bodied. I have a friend that suffers with Crohn's. Sometimes she's able, sometimes she's not, and she has a very a job that's not like physically walking outside. But the fact of the matter is, when she has a flare-up, she cannot work.
Robert Brown, thank you very much for that $10 super sticker. Another interesting data point. According to the Agency for Healthcare Research and Quality, 27% of uninsured hospital stays for ages 18 to 39 involve substance-related mental disorders. 29% involve alcohol-related mental disorders. 32% involve poisoning. 28% involve skin and soft tissue infections. This is just very, very interesting data in terms of the breadth and the scope of why people go to hospitals, the types of things that have to be addressed at hospitals, and if the administration isn't taking this kind of data into account as it just indiscriminately makes these cuts, there are a whole lot of folks that are going to be in a whole lot of problem and a whole lot of trauma in a very short period of time.
Yeah, I think, what I had in another interview to remind people of is that we have to, in order to stay at the hospital, some of us are on medications. So we have to look at the cost, the out of hospital care, just to stay healthy or just to maintain something. Your hypertensive medications, we have patients sometimes that are on 2 and 3 medications for a hypertensive disease. They're not, I guess, extreme examples of injuries and wounds that we have to think about. But, I have an aunt with asthma and hypertensive disease. She needs her inhalers, and she also needs her hypertensive medication. Not her fault, but that's about 5 medications that she needs. And so we have to also think about the cost that it takes to keep yourself out of the hospital, and hopefully you don't end up with an emergency visit. So looking at the cost of medications is a big consideration when we look at the cuts and how they're going to affect us.
When you look at the number of African-American doctors or doctors of color that are in the system, there is data that shows that when people of color see a physician of color, that their outcomes improve, lower mortality, better diagnosis. How do you see these Medicaid cuts impacting that? And you just touched on the impact that this can have on someone's ability to even be able to finance medical school.
Well, I want to be very specific. We look not just of color. I mean, I think these studies were done, specifically to say if they see a black physician,
Hmm.
and we just say, we have to recognize our community. When there's a Pepper Miller who looks at these studies and say, when you use words like BICOP and black and brown, we want to be very specific. We do know, and I can say from my own example that I grew up in a community of black physicians and had that reality that they were there, this was real. So we do know that there's really a connection that you can have when you talk to a black physician. I definitely see it in my space. I usually am gowned and masked and people can see my eyes. But yes, I do find that patients may respond to me more readily. And I'm going to say this too. You have to be responded to. You have to connect with your patients. But is it all of this is impactful on our ability to do what we've been trying to do and making progress over the last, I'd say, 20 years to increase the number of Black students enrolled in any medical school, not just Howard, not just Meharry. I went to the University of Texas Health Science Center, and that year they made a focused effort to increase their numbers of Black students enrolled in the school. They had no problems with the Hispanic or the white population. We have to figure that part out as a community. This will take intensive roundtables and also discussions, just like during COVID. So we got to kind of, I guess, get ready for the fight in terms of funding, in terms of messaging, and also talking to our youth to be prepared to look at options for medical school education. And what that is, we'll have to get creative and have conversations. When you say of color, I remind people that back in the day, Black physicians were not able to get on staff and be trained, and Cuba and South America became an option.
Hmm.
I'm not saying that we need to go to the Caribbean, but it just lets you know how we found a way to produce Black physicians during the hardest of times. I just want us to kind of have some hope there.
And quickly touch on. I'm glad you mentioned uh, Black medical students and specialties, because a lot of folks don't really realize
Mhm.
how segregated some of these special areas of specialization can be. And you need, in many instances, to have a benefactor to bring you in, to allow you to train. Ophthalmology is an area that comes to my mind. It's very hard to get into that specialty, especially if you're Black.
We're not segregated out. Okay, you go to your 4 years of medical school. You apply for an ophthalmology residency. There are certain specialties that we gravitate towards, because we've heard them. I mean, for instance, someone said to me, "Why do you want to be an anesthesiologist?" And we are small in number, so I think that sometimes the messages that we get don't allow our brain to think that we can do something, and we have to be encouraged. And this is when it becomes impactful to meet a Black physician in that specialty. I just met someone here at the National Medical Association, wanted to be a pathologist. And I told her, okay, well, let me introduce you to a Black female pathologist. And I think what you're trying to do is outstanding. That type of encouragement goes a long way for her to saying, you know what, I'm going to apply. So we have to apply. We have to get the interview. And there are strategies to get in your residency. And then from there, you move into your practice. There's a lot of mentorship and connections that need to happen. And I think that young Black students need to understand that that's what's important, that you need to connect, you need to build relationships. This
Mm-hmm.
is not what we call the Instagram relationship. Again, this is the NMA conference here in Chicago. I'm so proud to see friends that I have had since medical school. Like, it's amazing to walk down the hallway and know that you are in the midst of seeing people you've had a relationship with when you were struggling in college, and saying I wanted to be a doctor. And now you guys are, we're all 20 something years. This is a long haul. And some of us have applied to what we call, I think that's what you're alluding to, is the elite specialties:
Yes.
ENT, ophthalmology, radiology, dermatology. Yes, there is a distinct amount of studying, focus, connections. Yes,
Mhm.
medicine is a specialty, is an area of that you got to have have to have connections, in the sense that you have to have a relationship with people before you say, oh, well, I can apply, this will be great, and I'll just do this. But you need to understand what that application packet needs to look like. We kind of think of it like the military, when you want that promotion, and
Mhm.
then you go before a board. It's like that, and then it's not like that, meaning that your application doesn't go underneath behind a board that you cannot contest or figure out what you need to do to get into the specialty.
And Robert Brown makes the point, Black physicians make a difference. My son's godfather is a doctor from Kenya practicing in Atlanta. Over the years, the stories he shared about his patients also echo this point. And final question to you, looking at these cuts in terms of nursing home care, rehab facilities for people with knee surgeries and other types of things. Can you explain how the combination of Medicaid cuts and higher insurance costs will impact people being able to access these types of services?
Well, it's going to be tough because the orthopedic surgeon that is going to have to make some decisions about which cases he's going to accept and which cases he or she, I'm sorry, will not be able to take. Will it be harder? Before, was it early 2000s? I was practicing in New Orleans as an ER physician, and in the New Orleans area. And yes, if I had a young person with a broke leg, for instance, or they needed let's say they broke their hip in a car accident, uh, you had access to Charity Hospital to
Mhm.
be transferred to get your surgery. This is what this threats: this ability of our critical access hospitals to absorb free care. It will happen. There will be delays, not may. We anticipate delays. When it comes to rehab, this is a big deal in conversations for patients. We've identified Alzheimer's in younger and younger people
Mhm.
there, and they live a long time, God willing, with other issues, but that does at some point require long-term care. Any of us at any age could have an aneurysm or a stroke and end up in long-term care. So the funding for long-term care, I will be honest with you, is a major discussion that needs to have
Mhm.
a focus. So
Mhm.
that is when I say the hidden cost, and they haven't explained who's going to who's going to take on those dollars, or how those places will survive. You know, Black families, do take in and can care for their families, but then that family members, but then that also brings about the other conversation. How am I supposed to have a work requirement when now I have to have a brother that had a stroke and I'm involved with taking care of him because we could not find placement? How do I take care of my 19-year-old son that's paralyzed after a gunshot wound, and you want me to go to work? Well, I can't. In order to offset the fact that we can't afford good care for him, I have to be at home. These are real conversations with many families. I don't have an exact number, but yes, we need to. These are the conversations that our community needs to coalesce around.
And as we get out, your organization, Uzima, my
By
Uzima.
using mhm.
Go ahead, please.
byuzima.org. We have a newsletter, the active newsletter. Please go to the website and sign on. We are going to have a dedicated series called Just the Facts, and that will allow for you to follow conversations. You can even email me back and say, Dr. K, find me information about this particular subject and special group problem, and we'll look it up. Okay.
And folks, you can see the email, the website address there, scrolling across the bottom. Dr. Kendra Outler, thank you so much for your time today. Greatly appreciate that analysis. And it's been a minute, but this won't be the last time. Thank you.
Thank you.
All right, folks. I want to thank you all for joining me today. Thanking Dr. Outler, of course. Stay tuned. New episode tomorrow. And Ray McGovern is going to join us tomorrow. So be sure you're there. You're here for that. Follow, subscribe, leave a review, share the show. Follow us on social media. All the links are below. And remember that this is where the analysis of politics, culture, and history converge. Talk without analysis is just chatter, and we don't chatter here on Connecting the Dots. Why? Because we're rhetoric free. See y'all tomorrow. Ray McGovern tomorrow. Be here. It's going to be a big one, as the Moon Man would say. Until then, I'm Dr. Wilmer Leon. Have a great remainder of your day. Peace.
Thank you. Thank you.
Connecting the Dots with Dr. Wilmer Leon, where the analysis of politics, culture, and history converge.